from the wine to my talk about interlaminar endoscopy. The topic that I want to address today is about the history and evolution perspectives of the interlaminar endoscopy. So I have no potential conflict of interest. So you all know that some of the what is called the paradigm shift changes in spine surgery techniques, starting what we didn't yet previously past decades related to the big open incision related surgery, which was being downsized to the using the tubular retractors, what is called MED, microendoscopic compression, which is less than an inch incision treated on the backside. And recently, it has been furtherly downsized to the less than 1 centimeter, half inches, 8 millimeters, using the working sheath endoscope. It's going to be quite prevailing in recent spine society meetings. So, for instance, take a look at this very young physiotherapist employee working in my hospital. He has been under treatment with diverse pain interventions over 6 times, but still there's no possible and positive response coming from the patient. And he said, I really don't want to spend my time working on the surgery. So is there any other option that can be treated in what is called like MISS way, which is referring to about the spinal endoscopy solution for this big down migrate protrusion from L45, creeping on to the 5S1 level. So in the history, anyone who ever attempted and tried to manipulate those protrude ruptured discs away from the human body, the life, was Dr. Mr. and Barr working at Harvard Orthopedics way back 85 years ago. He created the start of the dynasty of the disc, which means that actually the time when he tried to remove the disc away from the human body, he used laminectomy, durotomy, transdurally, and approached the ruptured disc material, which was probably related to a lot of post-op complications at the time. Barely 5 years later, Dr. Love from the Mayo Clinic, during his staff meeting inside his hospital, said he can do the protrusive disc removal without doing any laminectomy or bony works. And this kind of attempt to try to remove all of this without any bony work or in some kind of MISS way has been silenced and have been noticed up to 30 years when in 1964, Dr. Smith reported in a very famous world journal of the Nature that probably we can dissolve all these ruptured discs away from the human body using enzymatic solution, which is called chymopapan. It was very popular and prevailing at that time, but it created a lot of complication problems because it does not only dissolve the nucleus purpureus that has been protruded, it also dissolves some portion of the normal tissues like dura, ligament of the plasma, etc., which is related to post-operative sequelae. So it has been silenced, but in the real history, anyone who tried to remove this away from the human body using percutaneous endoscopical way is the pioneer from the Japanese orthopedic arthroscopic surgeon, Dr. Hijikata. Way back 45 years ago, he reported in his own journal that named it as a percutaneous discectomy as a new treatment method. So under the suspension of Dr. Camby, you all know Dr. Paris Camby from Drexel University in the United States, that in 16 years later, in 1991, in JBJS American, he firstly reported about the safe triangle, what is under the safe triangle of the Paris Camby, which we now still use it as like Camby safe triangle for transforaminal access. So these are the pictures between Dr. Hijikata, Dr. Paris Camby, and Adam Schreiber from Switzerland. They gathered together way back late 1970s to create a society on the MISS, which is now being down and descended to the SMS meeting in the United States right now. So in the history, before the Dr. Paris Camby firstly reported about his own safe triangle, what is called Camby safe triangle in 1991, anyone who first used the terminology of the percutaneous endoscopic lumbar discectomy, which is still now being called as a PEID, is Dr. Michael Meyer from Munich in Germany 2 years prior, 1989. So it has been keep on developing both in surgical technically and also optically, and improvement has been proceeded on. In 1997, Dr. Anthony Young from the Arizona Phoenix first introduced rigid rod lens integrated multi-channel wide-angle operating endoscopy, what is called Young Endoscopic Spinal Surgery System, which is the prototype of the transforaminal endoscopes we still now use today. But when we are talking about the interlaminar endoscopy, anyone who describes terminology of interlamina, the anatomical structure inside the human body, is not by the Anthony Young or Michael Meyer or Paris Cambin. It's Dr. P.D. Antoni from Argentina in the Journal of Arthroscope, which is a German journal, in 1999, 21 years ago. And he used the terminology interlamina in German translation, while in the English translation, he used the terminology of the translamina, but this is the first report that describing about the spinal endoscopic access through the lamina and interlaminar spaces. This was very being, I think this is really pioneering work by Dr. Di Antoni from Argentina, but the thing is that he used two channels, which now we still call as a biportal endoscopic system, one for the working and one for the optics. And I think this is a really pioneering work from Dr. Di Antoni, but it would have been better that he properly used the interlaminar technique, even in the English translation. In 2002, in the World Spine Society meeting in Turkey, Istanbul, Dr. Park from Seoul has introduced 5S1 interlaminar technique in simple, barely poster presentation. So it was 18 years ago. And this is the first scientific presentation ever posted on the international meeting under the name of the interlaminar endoscope. So this is a very old video, way back 24 years ago in 1996. You see all these local anthrax being infiltrated on the dorsal, and that's the epidural staining. You see the serial dilator being clipped down, small incision on the back. Serial dilator is being inserted, starting from 2, 3, 4, 8 to down 5. This is 24 years ago, but it's very similar to what we do nowadays. Yeah, this is a very old video. You see that big, long transforaminal endoscope being inserted instead of a short one that has been intended for using interlaminar work. See, at that time, there was no Carrison or proper graspers or seizures that can be worked inside. No any kind of high-speed drill. So the instrument that we all have is a simple grasper and some side-firing laser to open up the medial portion of the bony work, even doing some laminectomy, open up the ligament flavum and visualize the nerve tract. And then after that work, we simply resect out this simple protrusion. That's very old video. There was no proper equipment, so that's the other thing that we could do. The thing is that this is quite similar work we could do, but the instrument is barely prototype. In 2006, Dr. Gunchoi firstly reported about, this is not a proper scientist index, but the thing is that he first reported about as like a part of technical demonstration about how to differentiate the approach access to the F5S1, to the interlaminar access for the 5S1 rupture disc, either by the shoulder type or axillary type of approach. So this is the shoulder type of approach, and you can see that the knob root is being picked up with this. You can see the protrusion material is shifting away the rupture material, and he's taking out the piece of the herniation in one piece to the shoulder approach. The thing is that in shoulder approach, you are not to be afraid of anything structures in toward your side because you have enough big space toward your side. And there's a big lump is coming out through the shoulder approach. Dr. Concha used to do all the interlaminar procedure on the patient in the laying down on the lateral position instead of prone. And you can see that the red arrow, you can see that the active nerve is in freeze right now. This is axillary type of the approach. See, in the axillary type of approach, you have to be very careful that one of your important exiting nerve root is toward your side, and the herniation material is clipped and kinked in between two important structures, between thecal sac and exiting nerve root. And that protrusion is being pulled out in between these two structures. So there's another protrusion coming out. But the thing is that you have to be aware that one of the nerve root is toward your side. So you should be very careful when you are using the forceps because it can be dangerous to hurt the nerve. Post-operatively, patient is free of any kind of limitation without any motor deficit. The patient was very happy. This video actually itself was posted on this operative neurosurgery publication 14 years ago. Any first pioneering publication that has been reported in Scientific Index, SCI Index, was from Germany in the same year of 2006, using his 331 patients followed at least 2 years prospectively. At that time, he used a 6 millimeter endoscope, which is much smaller than what we use nowadays. But the thing is that early next year of 2007, same author, Dr. Rutten, elongated this follow-up of his 331 patients to the 236 patients. And this was like being very highly remarked report. I should say this is one of the most first proper publication that has been reporting about the spinal endoscopy, especially Interlaminar, in the journal of that was regarded as a proper publication in terms of scientific evaluation. So in the year of 2007, he firstly used the 6 millimeter endoscope Interlaminar as like a part of publication in the Journal of Neurosurgery Spine. And the barely next year in the 2008, he actually performed a prospective randomized controlled study comparing this interlaminar discectomy over the conventional open surgery. 91 patients for the endoscopy, 91 patients same for this open surgery. And among these 91 patients, 53 patients was treated in interlaminar way. And they say is that in terms of a clinical outcome, comparing this MISS endoscopy with the full endoscopy, full endoscopy seems to be superior in terms of clinical outcome up to 2-year follow-up. And this study is very emphasized and evaluated because still, even in today, year 2020, this is still being the only evidence level 1 study regarded. So in terms of the EBM, this article that was published in year 2008, 12 years ago, is the only publication that is still being regarded as the level 1 class evidence. And in year 2014, there's a lot of some coming randomized controlled trial with high quality has been followed up, especially coming from China. One of the report from Dr. Li from Beijing, China in year 2015. He gathered 72 cases in a single year of 2011. And he said, before and after the interlaminar endoscopic performance, what could be comparable in terms of outcome for his 72 patient series? He said, in terms of sensation, the sensory and motor strength, and then tendon reflex, this is very interesting because the sensory and motor strength seems to be after 12 months follow-up period is being well recovered with a very statistically significant value. But the thing, what happened inside in the level of the axonal degeneration, which is being manifested through the deep tendon reflex DTR, it doesn't seem to be recovering that much. So we now know that the patient could be done with a good clinical outcome even after 12-month follow-up after interlaminar procedure. But inside in the molecular level of axons, which is being manifested through the DTR, there should be not so much recovery afterward. Dr. Peche, actually there's a lot of controversy, which is like being more preferred and more superior when we are dealing with the two types of the endoscopic procedure, either transforaminal or interlaminar. And Dr. Che has compared these two procedures for the 5S disc herniation. What was interesting that he tried to analyze the superior procedure of the transforaminal in terms of radiological anatomy. He measured every value, like iliac crest height, radiological parameter doesn't seem to be affecting the outcome that much. There was no any kind of some statistical difference between in terms of radiology. But the thing was that in terms of where the disc is located in transforaminal or interlaminar, anything that is related to the axillary or there's a like even there's some high seems to be better, while those who are located in a central or shoulder type of the disc protrusion with less than 50% of canal compromise, transforaminal seems to be working more better. So transforaminal centrally located and recurrent in herniation, while the interlaminar seems to be preferred for axillary and highly migrated disc, especially with those high grade. So radiology, even the iliac crest height doesn't seem to be affecting that much. And in terms of interpreting this procedure, which one is superior to the other? And similar reports are also coming from China in the year 2016 in the Barnier, that he did not compare anything in terms of clinical or radiological outcome. He tried to analyze which procedure is taking more difficult time or with the more high radiation exposure by the C arm. That transforaminal takes way up to 86 minutes of operation, while the interlaminar is less than 65. That's barely over 1 hour. Fluoroscopy time in terms of seconds, interlaminar seems to be less than few minutes, while in terms of transforaminal, it's way over 6.5 minutes. That means that both the radiological and clinical outcome seems to be comparable between the groups. The important difference between the two procedures is that interlaminar has advantage in terms of faster punctual localization, shorter OP time, and less radiation exposure, while the transforaminal requires a higher punctuation approach technique, has more radiation, subsequent more radiation exposure chances with a broader indication. So transforaminal seems to be more difficult. It could be only applied for the extremely lateral type disc herniation or sometimes a recurrent herniation only. So Dr. Che again in 2016, the same year, tried to compare how much height of the iliac crest could be allowed for the transforaminal access, and he divided into 2 types, starting from the base of the disc of the L5S1 level all the way up to the upper margin of the L5 pedicle. Anything that creeps more higher than type 4, which is the roof of the foramen of L5S1, iliac the foramen of L5S1, it seems to be unfeasible to approach transforaminally. And this is quite marked and quite prominent radiological report when we are trying to apply the indication for the interlaminar over the transforaminal. So interlaminar, I think you are all expert in doing the interlaminar endoscopic procedure, but I try to bend the patient a little bit in the flexor position so that I can open up the interlaminar space a little bit wider, like in this fashion. But the starting is very important. When you compare the two radiologic features between these two types of herniation, the one is axillar, the second one is a shoulder. Each one is reported in the year 2006 by Goncho. So this is axillar compared with the axillar approach, and this is a shoulder. I think this approach is totally different. You should know the anatomy of the interlaminar space before when you're doing the access. So left side is the shoulder approach. The right side is the axillar approach. See the consequent videos there. In the shoulder, in the axillar, you creep down in the one half of the middle of the base of the upper laminar space, while in the shoulder, you are accessing through the most superior lateral quadrant of the interlaminar space. As you go on, the needle is creeping inside on the right side of the images for the axillar herniations. So that seems to be what final location of the needle. On the shoulder approach, you have a direct access to the discal level, while in the axillar approach, you are a bit cranial, caudal to the L5S and discal level, because it's natural, because you are approaching from the upper margin of the upper margin of the lamina from the lower vertebrae. So that's natural that in axillar approach, you are slightly downward, while on the shoulder approach, you are directly accessing the discal level. So that's the serial dilator being inserted through the axillar approach. See, it seems like that you are penetrating sometimes to the thecal sac, but it's not it, because the serial dilator is widening up the space to create the space for the safety, and there is obturator getting inside. So that's the final location. On the left side, that your working channel seems to be really penetrating through the thecal sac, but you're still in the medial part of the spinal canal. So your bevel should be facing up to the level of the disc herniations. So that's the comparison on the left side and the right side, and axillar and shoulder approach. So one thing that you have to notice is that on the axillary approach on the left side, I'm repeating one more time, giving an emphasis. Nerve root, one of the important ascending nerve root is toward your side, and the important herniation is kink in between two important nerve tissues, between dural sac and impinging nerve root. This is very important. So when you're using grasp and working during the procedure, you should be very careful that your nerve root is toward your side. But on the right side, on the shoulder approach, everything is free except the protrusion. So you can easily resect out the herniation freely. So when you are not so sure about how to approach this differential approach between two procedures, it is sometimes useful to use the fiducial markers, like outdated on the left side video, the interoperable, and take an MRI and to locate the approach angle. I think sometimes that's helpful. If you're not so sure about how to get a proper access, you can have some fiducial marker attached to the patient back and give us some access directly. And the problem is that when you are trying to do the discectomy, it is important whether you are going to split the ligament flavum or cutting. Ligament flavum is the most first barrier that you have to encounter before the discectomy, before you are entering to the spinal canal. And it can be, this is one of the interesting cases of that wait back to 10 years ago. The terminal access for the L5S1 disc protrusion on the right side. But just a few days before the operation, the patient said his pain was becoming more lancinating, more cruciated. And we took another MRI and found out that there's a more big protrusion. So we changed the schedule from transforaminal plan to transforaminal to the interlaminar SS. And this is all video from Dr. Goncho, is that after resecting out the protrusion material, we are retrieving our working sheets along with the endoscopy for the view. After the discectomy, you see the annular defect. And now you can see the S1 nerve root is located into the normal position. As you retrieve out further, you can see that ligament flavum is being approximating each other. See? So this is a splitting of the ligament flavum for the discectomy L5S1. So L5S1 ligament flavum is approximate together. It's going to be natural healed and spontaneously approximate together. And afterward, this muscle is covering up. So we did not any manipulation to the muscles. So that's going to be really splitting technique of the ligament flavum in order to get an L5S1 discectomy. That was the conventional and most traditional way of doing L5S1 discectomy without any manipulation to the L5 covering ligament flavum. And Dr. Kim Cheon also reported the same. He used this splitting and under visual control. He said, in the shoulder type of the disc herniation, and L5, especially level L5S1, you can use the blade portion of the working channel as like a dissector. This blade of the working channel can be used as a dissector to detach the medial attachment with ligament flavum away from the laminar facet junction of the bone. And you turn this working channel 180 degrees and use as like retractors and do the discectomy. Then that's in terms of axillary of herniation, this approach might be more medial, but still the blade portion of the working channel could be used as like a dissector. And finally, after turning 180 degrees, it can be used as like a retractor to retract the thecal sac and do the discectomy. So this big protrusion at the L5S1, L4-5, see, there's only tiny remarks of the ligament flavum splitting evidence is phenomenal on the post-op MRI after full decompression. That's the way of doing this ligament flavum splitting for the 5S1 discectomy. That's very phenomenal. But the thing is that this interesting paper coming from Taiwan in the year of 2011, this is really one of the randomized controlled study using prospective control data. The thing is that the only parameter they compared is that during the L5S1 disc herniation using this splitting technique, which anesthesia might be better, either local or general. They said under the general anesthesia, patient is very calm down and he doesn't provide any kind of feedback, or he doesn't complain of pain. So you can do the endoscopy like in joystick principle, easy maneuver. But the thing is that you do not get any feedback from the patient. So there's a high chance that you can create some of the morbidity. While under local anesthesia, you have a continuous feedback from the patient during the procedure, which is like working as an intraoperative monitoring. And you can actually use this monitor to improve your surgical technique during the surgery and prevent further neural damages. So for the beginners who are trying to do the interlaminar L5S1 discectomy under local anesthesia, on L5S1 with a ligament flavum splitting, local anesthesia might be better solution rather than general anesthesia because you need a continuous monitoring from the patient. More interesting paper from Dr. Koga is that he actually performed 41 patients with lumbar disc herniation using this ligament flavum splitting technique. He said he measured and criteria every herniation into 4 types. First one from the shoulder, ventral, central, axillar, and central. He divided into 4 categories of herniation. Second thing he did was the measurement of the bifacetal distance, one side of the medial portion facet to the other. He said at least 22 to 24 millimeter of the bifacetal distance should be guaranteed to insert this 6 or 7 or 8 millimeter working sheets of interlaminar endoscope into the canal safely, 24 millimeters. He said he did every procedure among his 41 patients, 33 patients with the shoulder, while axilla 8% patient. But he had to encounter 3 complications from this 41 patient. See, the left side 3 images is pre-op. The right side image is about the post-op. The thing is that this, in radiologically, every decompression for these 3 completed cases is well decompressed, while the patient is still suffering from paresthesia and some of them even some motor weakness on the ankle. Why is this happening? Because it happens we are docking the endoscope, which is about 7 or 8 millimeters in the size, into the very creepy space of the spinal canal, which has been already compromised with the deep disc herniation. So we are docking the endoscope into the already very narrow and creepy spinal canal by the herniation. So that he changes paradigm from this ligament flavum splitting into any working cutting and doing some bony work by dividing the patient's interlaminar space morphology into 2 types. One, slit and triangular. Second is concavity is wider. So he said, for the patient with the L5S1 discectomy, doing bony work and ligament cutting, he tried to do the certain rest of patient for the more even narrow interlaminar space. So for the initial 41 patient, 26 millimeter bifacetal distance. For the rest 13 patient, less than 23. But he did not have any complication because he created the bony working space using Harrison's and high-speed drill. So for this kind of concavity shape, wider interlaminar space, he only resected medial portion of the SAP to create further wider space for the endoscope to be safely sneaked into the spinal canal to remove herniation. While in triangular, more slit and narrow space, he tried to do more harder bony work, including medial portion of SAP, upper portion of lamina, and sometimes even the medial portion of the IAP from the upper vertebra, medial fasectomy. So the wide of the defect of the bone is a little bit wider for this slit type of. After doing this creation of this wider interlaminar space using either Harrison's or high-speed drill, the rest 13 patients, despite they had less than 22 millimeters of interlaminar space, he had no complication. So this interesting case of mine, 19 millimeters of the interlaminar space. This is more narrower, but this is type of the approach that I use for like a shoulder. See this video. I follow the same track. This is S1 lamina, and that's the medial portion of the laminar facet junction between 5S1. And I stripped off all the muscles and attaching soft tissues. So that's gonna be the little portion of IAP and medial portion of the facet. Especially, I'm trying to undercut medial portion of the SAP to create a little bit wider space for the endoscope to be inserted. So that's the amount of the resection I planned for. After doing some medial discectomy, using this hooded shaver, which covers protects it from the thecal sac or ligament fold on the medial side, it's more safer way to do the bony work, even inside. After doing this tiny little bony work, I encountered directly with the S1 nerve root, and there's a covering ligament problem there. And underneath this S1 nerve root, there's a big protrusion. And now the nerve root can be retracted easily, while the endoscope can be snuck into the spinal canal without doing much damage to the S1 nerve root by excessive retractions. See, my blade portion is rotating as like working as a dissector, and after the S1 nerve root is freed away, see, my retractor blade is working as a retractor. And then I directly encounter with the ruptured disc and take out the piece away. So that tiny amount of bony work, especially to the medial side of the facet, gives a lot of space for the safe insertion of a spinal endoscope working sheath, as well as safe discectomy. So this is pre-op, and after discectomy, you see that small tiny bony work that I've done so far, and the patient is very happy to result. So this start of using this Harrison's and high-speed drill into the interlaminar spinal endoscopy procedure is expanding the indication for the application of interlaminar technique. So it is now being that we are doing even the stenosis decompression using over-the-top fashion. I'm showing you one of the interesting cases. This patient has two leg sciatica concomitantly, simultaneously, one on the left upper 5 left side and the other one in the 5S on left side, right side. So it was almost 10 years ago that I just imagined that one of the location of herniation on the left of 5 is over there, while the other side 5S on location is over here. So I planned that I might have to do the two interlaminar procedure in one day. So at the time, I was not aware of any kind of some contralateral approach. So I tried to simply do this two interlaminar procedures from the 5S1 space, one for the up, one for the down, as you shown here. But recently, one of my colleagues, it was almost 10 years ago, since we can do the bony work and stripping of the ligament flavum away from the spinal canal to create more space for the insertion, safe insertion of these working sheaths as well as endoscopy into the spinal canal, why don't we cross over to the contralateral side? So this is a contralateral interlaminar technique that has been prevailing and introducing the over-the-top decompression technique for the spinal stenosis. So that procedure, how the endoscope can be creeped on underneath the undersurface of the contralateral lamina, in between undersurface of contralateral lamina and ligament flavum on the contralateral side. And we can easily go into the contralateral side, medial portion of lateral recess, as shown here. And postoperatively, we do not have to do any kind of some real two operation, as the case I've shown previously. So this has been reported quite a lot in this fashion, that we are using the blade portion of the working sheath as like a dissector that creeps underneath the surface of the contralateral lamina. By turning 180 degrees, we can assess the disc herniation easily using forceps. And this has been further reported by Dr. Park. See, this is important. The blade portion is under surface of the spinous process of the corresponding level. See, using the blade portion as like a dissector underneath the contralateral side, by turning 180 degrees, you are encountering directly to the contralateral side ligament flavum and spinous process. So that's the first vision. Using the high-speed drill, you cover enough space. It's like a really over-the-top decompression fashion, and you can easily get to the contralateral side, even to the lateral medial portion of the pedicle to the contralateral side lateral recess. That's the creation and firing of the over-the-top stenosis decompression by interlaminar endoscopy. This is really getting popular and prevailing nowadays, even in my country, South Korea. So that's the fashion. So this kind of simple stenosis, see ipsilateral decompression and contralateral side. There's nothing else to be worried about. You see ipsilateral left side nerve root and the contralateral side. You can easily view the contralateral view, even to the contralateral medial margin of the pedicle. So application of the endoscope for the central canal or the, even spinal stenosis is being really controversial, but while it's getting very popular nowadays. So Dr. Lee has reported in year 2018 about the meta-analysis analyzing the interlaminar approach for the central and lateral recess stenosis. He included 5 papers from all the worldwide reported. The thing is that he divided the region of stenosis into 3. One into central canal, the other one foraminal. In between, there was lateral recess. Which approaches would be better? For the foraminal, it's natural that we chose transforaminal. For the central canal, I've shown you all the slides, the interlaminar would be superior. What about the lateral recess? It's going to be overlapping region between interlaminar and transforaminal endoscopy. But which one is better? There's still controversial. Lateral recess itself is a really controversial region in the anatomy. How can we solve the lateral recess stenosis? Important paper from Dr. Yuan again shows he divided lateral recess into the 5 zones. One starting from the vitrodiscal area, this is the discal area, to the upper portion of pedicle of the lower vertebrae. 3, highly migrated portion, like the lower portion of the lower vertebrae. Zone 4 is the roof of the foramen. 5 should be inside the foramen. It is natural that we can solve all these problems of the disc herniation or stenosis by transforaminally in zone 1, and even we can do some ventral facetectomy and even some resection of the pedicle in zone 2. And for the zone 5, where the foraminal disc or foraminal stenosis, you can easily use a transforaminal way. What about the roof of the foramen or even the pedicle, the lower marginal pedicle? That's a really controversial way. So he termed that zone 1, 2, and 5 should be approached transforaminal, while zone 3 and 4, which is matches to the highly migrated portion or even entry from the canal to the foramen, which is called lateral recess. Interlaminar working is much more better than transforaminal because in order to enter zone 3 and 4, you need very wide resection of the pedicle facet. So about this patient, which was controversial and presented early during this presentation, it was I had a very painful experience of this old lady, 58-year-old, which shows the same big protrusion from both 5A to 5S1 level. I tried to resect out this herniation in whole length by doing transforaminal ventral facetectomy, pediculectomy, and access to the medial margin of the lateral recess that is shown here. And I thought that I could do the enough decompression by catching the tail of the herniation. See, after the full bony work to the resection of medial pedicle and upper ventral facet, the lump of herniation that I removed was very large. I thought I made a very good success, but the patient after the operation said, I had the same pain remaining. And this, that I had a tail of the herniation still remaining, impacted into the lateral recess, zone 3 of the lateral recess. So I was very skeptical whether I should go convert to do open surgery to remove that tail of the herniation remaining inside. But one of my colleagues, Dr. Luke Kim from Catholic University said, why don't we try to do some kind of oblique access from not from the 4-5 level, by oblique fashion from 5S1 level to reaching up to the 4-5 level. So that's the axial portion of the L5. So I did a very oblique approach from the 5S1 level in interlaminar way to remove out this remaining tail portion of the herniation. That gives me a lot of clue that if I was having the patient with enough wider space of 5S1, why should I need transforaminal access? I can do interlaminar oblique access from the 1 level down, not from the 4-5 or 5S1, approach the oblique way to reach out this herniation even up to the 4-5 discal level. So it's a final vision that after second operation, the patient was doing fine. This interesting idea was actually being under my review for the publication in operative neurosurgery. See this interesting paper. I think this paper coming from either China or something, but he didn't think about twice. He just did the simultaneous two approach from transforaminal L45, one from the 5S1 level here. Two simultaneous approach, one from transforaminal and one from 5S1 interlaminar, inserting two endoscopy into together to remove out all this big protruder herniation from the 4-5 level, reaching to the 5S1 level. And it was published as like some old-fashioned way. So we do have a lot of very flexible grasper that allows us to disc removal in offset areas. So instead of going from 4-5 level, I did very oblique 5S1 shoulder approach. From here, reaching up to 5S1 level. Then by turning my working sheath facing over to the 4-5 level and inserting flexible grasper, I was able to catch out all these big protrusions in that way. This is very interesting. There's no big series for mine, but the future publication might be coming out using 12 patients. So the reason I have elongated my presentation for so far with the interlaminar technique is that I just want to emphasize one thing. For the past 12 years, up to 2012, what we performed in our institute of Urido, 10,228 patients with interlaminar or transforaminal endoscopy. We had to encounter 4.3%, 436 cases termed as unsuccessful removal. The reason for this unsuccessful is majority is by the incomplete removal. The reason for this incomplete removal is improper location of the endoscopy working channel into the wrong place. That's the biggest problem. So it's not about any kind of dural injury, and nothing about the hematoma collection or any kind of other familiar complication that we have to encounter. The biggest problem, the biggest reason for unsuccessful is that we are inserting the endoscope into the wrong location. That happened into 4.3 cases from our experience. So transforaminal is the prototype of the endoscopy, invented, created by Dr. Paris Cambin, and furtherly evolved by Dr. Anthony Young. And we are in the boundary of Cambridge-safe triangle since over 30 years, 3 decades. While the interlaminar, we are more familiar with all this anatomy because we are all approached by the open surgeries. For the transforaminal, 5S1 sometimes be demanding when you are dealing high iliac crest height for the level of 5S1. And since the transforaminal is more sophisticated and more difficult during the access approach, we are vulnerable to be exposed in high radiation by the CR. For interlaminar, you are doing a faster surgery. But the thing is that it doesn't have to be any kind of some trans prototype or radiation exposures or some amount of this protrusion. It is always challenging to achieve an ideal position of endoscope for herniated tissue, either by interlaminar and transforaminal. So having an idea of converting your pre-operative two-dimensional MRI and convert it into three-dimensional in actual operation upon the patient anatomy, it is seems to be very important. I want to emphasize this one thing for this presentation. 10 years ago, with Dr. Ron Juroski from Arizona, we published a textbook. In the time to provide the transforaminal approach and also the interlaminar. This year, my colleague Kim Sung Kim and Yongan, we purchased another furtherly detailed, further sophisticated textbook named Endoscopic Approach on the Spine with the Springer Company. It was published last September and last year, and you can easily get an access to this through the website and all. It includes a lot of videos and figures, so it might be more comprehensible for you to understand how to do either procedure easily with overcoming the learning curve. Thank you very much.
Oscar?
Fantastic, fantastic presentation, Professor Lee. Thank you very much for your time. Anybody questions for Professor Lee? Put here in our chat. Professor Lee, we have one question for you. Okay.
Yeah, no problem.
Okay. What is your experience and opinion regarding biportal interlaminar endoscopic decompression for stenosis cases?
Could you repeat? I just see the faint voices. I'm sorry.
The biportal interlaminar endoscopic decompression for stenosis cases. What's your opinion?
You mean the big biportal?
Yeah, biportal, yeah.
Yeah. So actually, this biportal concept of this biportal endoscopy comes from the usage of joint arthroscopy applied on the spinal endoscopy procedure. So actually, it is more familiar and more easier. The same technique over the spinal problem as well. But the thing is that I think the biportal endoscopy, they say it's much easier than monoportal because you have a more wider two channel, one for the optics and one for the working set. So an inserted instrument can be same as what you're using during the open procedure. But the thing is that if you can solve one problem with using one portal, system to do everything, you don't need to use biportal system. But they say biportal is easier, but you have to think about the necessity. Either can be a good solution, but once you are really endoscopy using one portal system, you don't have to use a biportal.
Okay, okay. What is your opinion, Davi, about the biportal and the uniportal endoscopic decompression? Do you have an experience?
By myself, I don't have any kind of experience with the biportal approach. With the uniportal, you may decompress both the lateral recess and the central canal stenosis. But I have a question to Dr. Gino Lee regarding the way that he approaches the spinal canal when he has to perform a simple case of 5S1 disc herniation, right? So
yeah,
if you are planning to make it through the interlaminar approach, how do you, because I've seen in your presentation that you have two kinds of techniques. First, that you presented is you make the puncture direct into the disc or into the S1 vertebral body, and then you dilate, and then you insert your working cannula, your working channel, right? And then you
yeah.
insert your endoscope. And I've seen that you've shown to us that you use sometimes the other technique. Then you come from the ligamentum flavum, then you open it, and then you come into the canal. So which one is your choice when you're dealing with the L5S1 simple centrolateral disc herniation? How do you make to go inside the spinal canal?
That's a very good question, because David, that's very important. Yeah, because if you want to simply get a direct access to the herniation without doing any surgical manipulation to strip off any ligament flavum or medial portion of the bone, the patient should have a proper wide enough interlaminar space available. So that can be measured through the before the operation by through preoperative X-rays or preoperative MRI, that how much space is available lateral to the exiting S1 nerve root, between the medial portion of facet to the S1 nerve root. It is very important that the herniation usually shift this S1 nerve root either medially or laterally, because herniation is large, then S1 nerve root naturally will be shifted medially or laterally, either by shoulder or axillary type of herniation. The thing is that when you have to encounter this nerve root, because the herniation is ventral to the nerve root, then there's very important chance that you have to strip off the ligament flavum first, identify the nerve root, and then safely extract it and take it out. So it depends on the two important things: how much space is available. Second thing is that where is the disc herniation and where is the nerve root is being shifted away by this herniation. So if the nerve root is widely deviated away from its normal location, you have a wider interlaminar space. You can do simple discectomy without ligament flavum cutting. But if the nerve root is in the way of your access, then it is very essential that you have to create first safety margin by visualizing the nerve root first, and then safely retracting it, and then do the discectomy. I think this is should be emphasized.
Very nice. Thank you for your answer. And one other doubt I have, another question, is regarding the kind of anesthesia that you use. Do you prefer the local anesthesia or the general anesthesia when you perform the interlaminar approach?
Yeah, David, you know that when you are here in Seoul, I always did all the approach under John. I was very not so much experienced with the interlaminar procedure at that time, because that was like a safety margin that I have to get from the patient. Even though that the patient will suffer from laying down on prone position for over an hour, I have to be very careful that I need to get a direct feedback from the patient that I'm doing something right without provoking anything to the nerve root of the patient. Once you are overcoming the learning curve and should become an expert to do faster surgery, then probably you can do a general procedure general anesthesia without any danger. So for the beginners, I'm repeating, probably you have to get a feedback from the patient during the procedure. While you are becoming more skillful and expert, then you can use a general anesthesia for your convenience and also for the patient.
Great. And one more question. I know that our colleagues, Mosca, Facundo, and Marcus, they have questions for you. But I have one more question. When you have, for instance, I believe that it's a very common situation. Mostly in middle-aged patients, I believe most of them around 50 years old, 55 years, early 50s years old. Some of them, they have together the lateral recess disc herniation together with the lateral recess stenosis. Which one is your approach, your access of that you prefer to deal with this kind of problems? Do you prefer the interlaminar approach or do you prefer the transforaminal one?
I should say that for the lateral recess, it's very controversial region that cannot fully be addressed with the out of the facet joint and pedicle, while for the interlaminar space, also the upper portion of the lamina of the lower vertebra and also as well as the medial portion of facet should be all resected off. So the thing is that it depends on the how much the stenosis and how creepy is the spaces. If the space is very narrow, then I would rather recommend that interlaminar work would be better, because the surgeon should have a more familiar with the anatomy of the procedure by doing interlaminar access. If the patient height is very narrow, this is now, so you can do a minimized resection of the facet, then you can do a transforaminal. But usually for the lateral recess, transforaminal seems to be creating a lot of problem by creating post-operative instability later on. So for the lateral recess entry, I rather recommend interlaminar. It would be much more better than transforaminal in terms of stability sake.
Great. So I'd like to open for our other colleagues here, to Marcus Serra. Do you have any question to Dr. Lee?
Yes, yes. It's very hard.
David,
Wait,
pode falar.
no, it's very hard to create a question for Dr. Lee after this presentation. Okay, because it's very complete presentation. Thank you for your time and thank you for presentation. So to higher levels, what's your approach? Would you prefer interlaminar or transforaminal approach for L2, L3, or 3, 4? What's your approach for higher levels?
I should say that the thing is that for the higher level, like L1, 2, or 2, 3, I think the transforaminal seems to be a little bit better because you have a very wide transforaminal, while the interlaminar space, it doesn't have to follow that track because it depends on where the pathology is located. So I rather recommend that it has to be depend on where the patient, how the patient anatomy is and how the pathology is. But conventionally, they said for the upper lumbar level, transforaminal is better because you have a wide foramen while narrow interlaminar space. While for the lower lumbar, you have a narrow foraminal space while the wider interlaminar space. So that's conventional idea, but it depends on patient pathology and how the patient inherent anatomy is.
Okay, thank you.
Facundo, do you have any question to Dr. Lee?
Oh, thanks, David. First, I want to thank Dr. Lee for his wonderful presentation. Thanks for taking the time to be with us here tonight here in South America and at the morning in South Korea. Just a brief comment about what you said about Dr. De Anthony being the first doctor to even report an endoscopic procedure to the spine. Actually, you know, I'm an Argentinian, and we Argentinian love to talk about others Argentinian. So Dr. De Anthony, he kept doing the endoscopic procedures. He kept doing some kind of UVE procedures with arthroscope like endoscope. And the last thing we knew from him is that in 2005 he did surgery to the son of the Libyan leader Gaddafi. You know Gaddafi?
You mean Libyan leader Gaddafi?
Yeah, Dr. De Anthony did a spine surgery to remove this herniation that Gaddafi's son had. Gaddafi's son is a football player, a soccer player. So he needed a surgery, and they came to La Plata, that's Argentina, to visit Dr. De Anthony. And they took Dr. De Anthony and his wife in a private jet to Libya, and they performed the surgery to Gaddafi's son. And fortunately for Dr. De Anthony and his wife, the surgery went well, and it was a happy ending. So it's a brief comment about your talking about Dr. De Anthony. I had actually two questions for you, Dr. Lee. The first one is regarding the new technology endoscopes for stenosis, to treat stenosis. You know, the ones that are a little wider in diameter and are specially designed for stenosis. Do you use them? Do you think they're useful, or do you think that they are maybe too big to do stenosis surgery?
Actually, the recent development and some of the progression in the endoscopic companies they are trying to develop more wider parameter of the working sheets as well as the instruments, so that we can just mimic the open procedure under the name of interlaminar endoscopy. So even some companies are creating over 1.2 centimeter, even like a half inch of the diameter of the working sheets, which was used to be like less than 7 or 8 previously. So if the size is getting bigger, then you can have a more freedom to insert the conventional open technique equipment into the through the working channel, and you can just mimic all the procedure like what you're doing the open procedures previously. But the thing is that we have to consider that the necessity of this wider caliber, because if you are very equipped with the proper surgical techniques and if the equipment, everything works properly, then why do you need to create a larger caliber? They are using some other excuses that we are trying to do in the future, one of the endoscopic lumbar interbody fusion. So we probably need a more wider caliber to properly insert this implant, this minimized compacted implant through the working channel. But it depends on the future development. So currently, I should say, as of this year, probably we are almost satisfied with the procedure with the same calibers that we used to, less than an 8mm currently. But as some of the technical evolution is related to the making more convenient, making the surgeon more convenient, but not for the patient because they have a more increase in size. Or in either way, probably in the future, endoscopic fusion might be applicable with this more wider and more bigger caliber of the working sheets of the endoscopy.
Thanks. I have another question for you. Um, in 2019, some Japanese group wrote a paper about using MRI and CT fusion to define the position of the nerve roots regarding the interlaminar window. When I read it, I thought it was really useful, but not really practical in our settings. Do you use fusion with MRI and CT to locate the roots before surgery, or do you think this maybe for research process?
I think that, yeah, I think I totally agree with you on that, because fusing the MRI and CT images to identify the location of a nerve root, I think that's very overwhelming. Yeah, it's too excessive. If you want to truly identify the nerve root, you can just simply do some other procedure like some preoperative myelography, or even some more detailed thin section of the MRI scan to locate the nerve root. That's going to be an easier way to identify the nerve root. So combination of two modality between MRI and CT to simply just to identify the nerve root location, then I think it's too overwhelming. So I totally agree with you on that. I think that's too excessive.
Okay, and the final question before I leave you with the others moderators. You discussed very wonderfully in your presentation about the differences in approaching a lumbar hernia, with the axillar and the shoulder approach. Now that we have high-speed drills, endoscopic drills, do you think it's worth it to go with the axillar approach, given the fact that it's often more dangerous to the nerve root? Or do you prefer to maybe drill a little more in the shoulder, expose the shoulder and go through the shoulder?
I think that it is more convenient for you, all of your surgeons who are used to do the open surgery. It is more convenient for you to start from the shoulder portion of the interlaminar space, because actually that axillar location, the upper portion of the lamina and the middle portion of the SAP, getting entry to the safe lateral recess, that's the most brittle and most shallow covering layer of the bone over the top of the ligament flavum. So it is sometimes very demanding to start from there. I think you all agree on this, because shoulder, there's a big width of the bone covering up the ligament flavum. So you can simply starting the bony work as you to do the open surgery. So for your sake, I think starting from the shoulder and way down to the medial portion of facet, reaching up to the upper portion of the upper lamina of the lower vertebrae, I think that's more easier for you to do that, because you are all know that the covering bone layer from the shoulder, it's more, you are familiar. and more thicker. So you have a more safer. But starting from the directly over the lateral portion, I mean the upper margin of the lower lamina or medial portion of the laminar facet junction, it's sometimes very demanding. It's a very brittle area. So it depends on your surgical skill, but once I get used to this interlaminar procedure, I directly go for the lateral recess nowadays. But if you're not so sure or feel not so safer about this, then you better start with from the shoulder, what you used to do during the open surgery.
Okay, thank you so much for being here. Thank you for your presentation. I hope to see you face to face really soon here, maybe in South America.
Yeah, I definitely open that. Thank you very much.
I've seen that Dr. Mayer, do you remember Dr. Mayer, Dr. Lee? And he was in Korea 1 year after I went there. So he has a question here. Maybe he wants to open his microphone and to make personally his question for you. I believe it's very interesting.
Hello, everybody. Can you see me?
I
Can you
didn't.
hear me? Dr. Lee, thank you very much for your presentation. And my question is about recurrence, especially when we are dealing with a large defect, herniation with a large defect. And have you got any strategy to avoid recurrence in those situations?
You mean about the recurrence for the highly ruptured disc? Yeah, there's actually no definite solution currently because you know that there is no any kind of some artificial method to cover up all the annular defect creating during after the rupture of this bone or during the discectomy. So in order to deter the disc recurrence, I think there's no clear solution. I used to do some of the ablation on the annular defect over the rupture site to just simply do some sealing of the disc defect to deter the recurrence, but that doesn't seem to work fine in terms of deterring the recurrence. So I'm sorry, but there's no definite clear solution to deter the recurrence currently available now.
So I have one more question. Do you believe that there is any kind of difference of the rates of recurrence when you compare the transforaminal and the interlaminar approach?
Actually, I analyzed by myself the last year in the Journal of World Neurosurgery, last December last year, I analyzed some of the comparative results between the endoscopy and open surgery. And I thought the main emphasis was that whether that annulus puncture during the endoscopy by using obturate or working sheaths could furtherly propagate any further recurrence. Actually, there was no difference in terms of surgical method between the endoscopy and conventional open surgery in terms of recurrence. So it is really vulnerable to what the patient original inherently has the capacity. And second thing is how much the herniation and how much the annular defect has been created. But it is not being artificially decided by surgical approach. So currently there's no difference upon the evidence. There's still no difference between in terms of recurrence between the open surgery and endoscopy.
But regarding not the open and the endoscopic, I believe I mean the difference between the transforaminal and the interlaminar approaches. Do you think there is any kind of difference of the rates of recurrence?
So it depends on how much the patient has a really wider annular defect before the operation. So usually the interlaminar, we are applying it to the very highly migrated disc with a large canal compromise. So the starting point is different. For the transforaminal, you are dealing with a lot of some small focal protrusion or some of the contained disc, while interlaminar, your application might be more preferable over to the highly migrated, more wide rupture disc with more canal compromise. So in terms of interpretation, interlaminar seems to be more higher in terms of recurrence. For the surgical procedure itself, I think there could be no difference between the transforaminal and interlaminar in terms of recurrence by the surgical manipulation.
So do you believe that you during the last years you changed the approach that you prefer from transforaminal? Did you move more into the interlaminar approach of choice when you, depending of the indication of the surgery, or what's the approach of that you prefer when you have in the intracanalicular disc herniation? Do you still prefer the transforaminal, or did you move a little bit more into the interlaminar?
I think that David, I still prefer transforaminal personally because I'm familiar with that because I'm trying to do the procedure over other procedures, like even in the interlaminar. But in terms of science or evidence, I think both should be equivocally approached in terms of where the pathology is and how the patient's anatomy is. But as I shown my slide, nothing is more superior, nothing is more preferable over one over the other. But I think since I'm the transforaminal surgeon used to be, I still believe that it still has been more vulnerable to the surgeon's choice by their own preference.
Great. Does anybody here have any other question to Dr. Lee? Marco Serra, do you have another question? Mosca?
No, for me it's good. Good presentation.
Facundo?
It's all clear.
Sorry? No other questions?
No.
So, Dr. Lee, thank you so much for your presentation. Thank you very much for your opinions. Thank you very much for your considerations here to join us in our presentation. It was a great success here that we had many surgeons that followed our webinar. So we are all grateful to you. So we now we can drink some wine now because it's evening here in Brazil, even though it's Sunday, it's Monday. So thank you very much.
It's very good.
That's gonna be Chambly Eloise.
Very good.
And that's gonna be Chambly.
It's for the evening. Yeah.
I'm enjoying 12 hours later. But this is more here, so.
Very good.
Nice.
Thank you for accepting our invitation, Professor. Thank you.
Thank you, Dr. Lee. It will be
Thanks, Dr. Lee.
a pleasure.
Have a nice day.
You too. Enjoy the wine and I hope.
Thank you.